Good afternoon, everyone. My name is Lee Clark. I'm the Episode Design and Delivery Manager here at DHS and Medicaid, and it's my pleasure this afternoon to talk to you about thresholding. First of all, let me talk a little bit about the Payment Improvement Initiative itself. Of course, what we're hoping to do across this multi-payer initiative is to improve the health of the population of Arkansas, enhance the patient experience in care and receiving care, and reduce or control the costs for that care. And there are several strategies that we will be using in the Payment Improvement Initiative to achieve this. Certainly there's episodes of care, which we'll talk about the thresholding related to those today. And, what an episode basically does is give you a common definition of what a service is, a start date, a stop date, what kind of treatment is included in an episode, what kind is not, what kind of patients are included in an episode, which ones might be excluded or eliminated because of certain risk factors, and we'll talk about that some more. But two other things that are included in this Payment Improvement Initiative are health homes for the behavioral health, developmental disabilities, and long-term services and support population, and the patient-centered medical home, which will be emphasizing coordinated care for Medicaid recipients. Other things that are being implemented to support the Payment Improvement Initiative are healthcare workforce development, consumer engagement, emphasizing personal responsibility, and then, of course, health information technology emphasis. Through this process of looking at episodes of care, we've worked very closely with many people throughout the state, both providers, patients, family members of patients. There have been more than 1,000 individuals who have helped shape this new model of care in public work group meetings. There have been 29 public work group meetings that have been conducted through 6 to 8 remote sites across the state using video conference facilities. 26 months of research, data analysis, calling on experts and getting their opinions, and designing the infrastructure to support the Payment Improvement Initiative have been undertaken. It really is a lengthy, well thought out process. And then, of course, every month the provider associations, whether it's the Hospital Association, the Medical Society, the Arkansas Waiver Association, or the Developmental Disability Provider Association, they're all briefed on what the latest developments are. We currently have 15 episodes, 5 of which have gone live. The others are in some stage of development. And on this chart, you can see reflected those episodes and the payers which are participating in them. I did mention earlier this is a multi-payer initiative, and Blue Cross Blue Shield and QualChoice are both participating in the episodes you see indicated.
Good afternoon. This is Anita Castleberry, and just want to let you know that this is the third in a series of webinars regarding the episodes. In May, we went through and discussed at a very basic level how the ADHD episode was built, all of the decisions, as Lee mentioned, clinical work groups that helped us to identify guideline concordant care and the needs for 2 different levels for ADHD, really participated and helped to shape that particular episode. Then, later in May, we came back and we talked about how a couple of the detailed pieces involved with forming an episode. We talked about quality metrics and the portal and how we were intending to measure quality for the episodes. And we also talked a little bit about the reporting mechanism that we are building to support episode-driven care. So today we will focus on just a very basic webinar about how the thresholds are built and how the whole, to really pull together how the episode model works. We did use 5 guiding principles that to determine cost levels, those being commendable and acceptable thresholds, and to determine the incentive payments. The very first thing we wanted to do is be sure that we reward high-quality, efficient delivery of clinical care. So we really wanted to take those clinical guidelines that have been proven to be effective, across the board for the particular diagnosis and reward a pay or model based off of those. We wanted to, we do want to promote fairness by considering patient access, provider economics, and changes required for the improvement. We also acknowledge that poor performance is a reality and that should not be rewarded. We aim to protect quality and access by setting a gain-sharing limit at a reasonable, achievable limit. So not only do we understand that we have poor performance in overutilizing, we also wanted to protect and make sure that beneficiaries get the correct amount and we don't have underutilizing occurring in our system. So we do have that gain-sharing limit on the lower end. And then the fifth thing is we really want to sustain thresholds for a reasonable period to allow for adjustment and learning. So with that given, the clinical work group worked through with us and determined that we really needed to take this first year and sustain our thresholds so that we could have enough data to go back and look at what we've learned in the first year. And so there still seems to be a good bit of confusion about how this payment system works and how it's integrated into our current payment system. One of the first things that we learned as we took on the goal of bending the Medicaid cost curve and payment improvement initiative was that we decided very quickly that we didn't want to change our existing fee-for-service mechanisms totally and just go totally away from those. So what was determined that would fit best for Arkansas was to work within that model and do a retrospective type of thresholding to compare against what our current fee-for-service model provides for. So in addition, and please keep in mind, again, that in addition to your normal payments, we have designed a commendable threshold so that if your average costs are below the commendable threshold and your quality standards that we talked about last month are met, then you share in the savings that occur because of meeting the threshold. There will be an acceptable threshold so that if your average costs are above the acceptable, you'll still have to you will have to share with the additional costs. So if you go over that acceptable threshold, then there is some risk share, and you'll be expected to pay back some money. There will be a gain sharing limit as well. So if your average costs are below the gain sharing limit and the quality standards are met, then you'll receive a share of the savings up to that limit. So again, there are 3 different thresholds. There's a commendable, an acceptable, and a gain sharing limit. So what does all this mean to you as a provider? What it really means is that there can be many winners in this thresholding episode type atmosphere. The aim is to have as many providers receive rewards as possible, and the risk-reward levels are set so as to make that a reality. So again, as the thresholds for each and every episode were set, all the factors were considered about what should care within the Arkansas system look like based on the guidelines for that particular diagnosis. There were a lot of other factors were factored in. For instance, we know that in some areas services aren't available in the same manner or fashion that they are in other areas. So outliers were considered. Ages of the beneficiaries were considered in crafting these episodes. So those are just a few examples. And Lee is going to lead you through the next set of slides to explain just exactly how those thresholds were developed. Lee?
Thanks, Anita. Certainly what each payer has done is look at, for a given episode, what their historic provider average costs have been. And those costs would include everything that is included in the design of the episode, whether it's pharmaceuticals, inpatient, outpatient, whatever mix of services has been included in that episode. Each payer goes back and looks at those costs. Then, relative to those costs, they select the thresholds that they believe promote high-quality care based on those clinical inputs, the best practice knowledge that's been developed by healthcare professionals, and what is believed to be cost-effective care. You see on this slide the 3 levels that Anita mentioned previously: acceptable, commendable, and gain-sharing limit. Those selected thresholds are applied to a provider's performance, and even though there is expected to be somewhat of a shift in cost simply by putting the episodes in place, we still expect those to promote cost-effectiveness. Providers that meet the quality standards and have average cost, those are the costs that are seen between the commendable and gain-sharing limit, actually share in the savings to each payer's program. Providers with average costs that are between commendable and acceptable, they neither risk share nor gain share. What they have been paid for those claims already based on their paid claims amount is all they will receive. Now, for providers whose average costs are above the acceptable limit, those are represented on the left-hand portion of this slide. You can see the pink bars. Those providers will have to share in that excess cost. So, for providers to actually participate in gain share, not only must their costs be between the gain sharing limit and commendable, but they also must meet the quality metrics that have been set. So, we have lots of providers who want to know how one individual patient might affect their numbers. What it's really important for everyone to understand is that it's the average cost that count. So, extraordinary cases that may exceed cost and are an outlier, those are actually excluded from the analysis. Other extraordinary cases where the patient may have a comorbidity or some other factor are removed based on a clinical exclusion. And where appropriate, cases are risk adjusted based on age, comorbidities, and other factors. For instance, if a patient has pneumonia, diabetes, or is obese, that may well be a risk factor for that particular episode. On this slide, you see where an individual provider might fall compared with other providers providing the exact same episodes of care. So let's take a look at how we established his performance. For each principal accountable provider, or PAP, the actual costs for each episode are certainly going to vary across their patient population based on patient needs and the kind of care that goes into treating the patient. What we're looking at here is a distribution of unadjusted cost across all of one episode for an actual provider. Please note on the right-hand side that there are some high-cost outlier patients included. Okay. Then the risk adjustments that I mentioned earlier are applied, and you can see in some cases that actually does adjust down the cost for select patients that this provider has treated. And then the outliers, those on the high end on the right-hand side of the slide, they are removed from the cost calculations for this principal accountable provider. Then the average adjusted episode cost is determined. And as I said, those costs include all components, all of the inputs, all of the care categories that goes into a patient care. This slide is pretty indicative of the different kinds of treatment decisions made by individual providers and the differing contributions that outpatient, inpatient, pharmacy, or professional claims may have to an episode. So as you look at that individual provider, all of those components are taken into account when calculating their cost for the episode, and that's how they end up being in that place on this graph for their threshold.